You're listening to Health Professional Radio. My name is Wayne Buckler, and this morning it's Health Academy, and my guest today is Professor Andrew Georgiou. Andrew is an Associate Professor at the Centre for Health Systems and Safety Research, and that's part of the Australian Institute of Health Innovation at Macquarie University Hospital. Andrew, welcome to the Health Academy and Health Professional Radio.
Thank you. I'm really pleased to be with you.
It's our pleasure to have you on this morning. Now, Andrew, most of our audience are clinicians of one kind or another, often working in acute care, and they're always interested to know what's happening in the world of academic research and the academy generally. Tell me, what's your area of interest?
So my area of interest is health informatics. Health informatics involves the role that information and communication technologies can play in improving the quality and safety of healthcare. Health informatics is a pretty broad area, so within that area I'd say that my particular specialty has been in the area of pathology or laboratory ordering, where clinicians make orders for pathology tests alongside medical imaging. I've become very interested in that area as well. And I guess the other area that I have a particular interest in, and I've done a lot of research in, is in aged care informatics, and that's where clinical systems and administrative systems can help in the better coordination and improvement of care for aged people in the community in particular.
Now, for many years in health, IT and informatics was pretty much restricted to coding and making sure that the billing was done correctly. It's in recent times has been a fairly hefty investment around the world and in Australia in systems that are actually involved in bringing information technology to patient management in a clinical sense rather than in a financial or administrative sense. That's the field you've been working in, I gather. What's happening?
Yeah, so you're right. IT or information technology in the old days tended to be a very specialist sort of thing. It was mostly around billing or coding, or it tended to be limited to a particular section. So there might be one section of the hospital that has some fancy IT system, but it was just that section rather than throughout the hospital. So we've now moved on. What's happening is that we're getting integrated systems. So we have a thing called the electronic medical record, which what that does in a hospital, say, is that it links up the data, say, from the pathology lab to the administration data to other elements of critical information. So a clinician or a doctor, say, might be able to access the information at one point, and it's not just going to three different places, it's all there in front of them. So it maintains a continuity in the sense that you know what's going on immediately. And by knowing information about a patient, when you come to order a pathology test or come to put together an order for a medication, you actually also get to know things that are important to maintaining the safety and the quality of that person's care. So, for instance, if there's a sort of adverse reaction that might come because a patient has a certain condition, you might have that information, or it might be part of the decision support feature of the system. So it's for those reasons, the fact that we're now talking about a hospital-wide system, that we're now able to integrate information, that we're actually starting to see the potential for massive improvements. So it's no wonder, therefore, that a lot of governments, or health planners, administrative bodies think that this is a great way to improve health. There's efficiencies involved, and there's lots of benefits that are potentially out there.
You're listening to the Health Academy with Health Professional Radio. My name's Wayne Buckler, and I'm in conversation with Professor Andrew Georgiou. Andrew, there's some level of cynicism about the adoption of electronic health records and IT generally in the health system around the world. There's been a number of, I guess you'd call them, high-profile cases where systems have not gone into use at the cost and timeframes that were expected. Sometimes there's pushback from clinicians who describe this as turning them into data entry experts or cookbook medicine. What's your feeling from your research? Is this a program that's going to be successfully implemented globally?
So that's a very good question, and it's something that I think time will tell. It is true that, particularly in the 90s, when I sort of first got involved in health informatics and health information technology, and I was working in the NHS in Britain at the time, there were some massive failures, very expensive failures where things actually went terribly wrong. And there was a lot of rethinking that went on. I think the other thing about that was I think the NHS at the time, coming around the turn of the century, actually even had a grand plan to put together the NHS information strategy, which wanted to introduce electronic systems. And it didn't go according to plan, and overspent, and there were many problems with it. I think there's been a lot of rethinking about it, and one of the things that has become very clear is that IT, the introduction of IT into healthcare has lacked that strong evidence base. What's happened is that there's a sense of, oh, well, here's an IT system, it's going to work, it's going to improve things, let's just put it in there. Rather than the sense of, well, should we evaluate it? Should we make sure that there is evidence for it? Should it be safe? I mean, we do have a lot of conditions for introducing new products in health, new surgery, new drugs. How come we don't have that same attention to IT systems, which are incredibly expensive and actually have the potential to cause harm as well? So yeah, it's been an up and down story. I think for every great news story, there's also an occasional bad news story, and sometimes the bad news stories dominate. For instance, if a system goes down one day, everyone will remember the day it went down, maybe rather than the 348 days that everything was fine. So yeah, it's very challenging, but I think that the role that I see myself playing and our Centre for Health Systems and Safety Research is that we really want to provide the evidence base for making good decisions about the design of these systems, about their implementation, and about sustainability, because there's too often a sense you put it in and that's it. And you need to have systems that are sustainable and change over time and improve over time, actually.
Yes, and I guess in the success side of the coin, private pathology has been running health informatics very successfully for a long time now, and also intensive care. There's been ICU systems that have been implemented and working effectively for a good while. Is this going to be a generational change? Do we have to wait for a new generation of doctors with iPads before we see widespread acceptance?
My feeling is that we're already seeing those changes, and sometimes it's not so much an age thing. It's more just proof that it works, confidence that it can work. I mean, better to say the challenge with health information technology is that when you introduce a new system, it actually changes things dramatically. So, for instance, initially when we introduced new ordering systems, there was a tendency to design it just like it was a piece of paper. So you design a screen just like it was a piece of paper, so you're filling in the piece of paper. And the problem with that is that IT has much more flexibility. Computers can do a lot more things. You don't have to fill things in twice, 3 times, 4 times. So we need to sort of, IT allows us to be innovative. So we need to have a sense of we're making innovations. Now, innovations cause major disruptions. They cause major changes. And unless you're prepared for them, unless you sort of predicted them or able to deal with them, there's likely to be sort of a bit of concern, likely to be perhaps a bit of resistance to new systems. So I think that they're the challenges. IT is not just a substitute for paper, it's actually a new concept and that needs to be thought of like that. So I'll give you an example. When when a new system in an emergency department, there's also always a lot of concern about time and efficiency. Lots of people coming through. We need to sort of make sure that there's a smooth flow of patients through the hospital and through the ED. Now, initially, ED, there was a lot of stories about how slow the computer system made things, and there was a feeling of, well, if you measured the time it takes a doctor to make an order on a piece of paper to the time it takes to make an order on a computer, the paper's quicker. And I remember, almost a decade now, we even sort of recorded the time and looked at how things changed. And sure enough, when a doctor makes orders, they might make them, in a great big bulk sort of time at the end of every 3 hours or something, and they just scribble through them, and it's all done very quickly. Whereas with a computer, you actually log in, log out, wait for it to come up. There's all sorts of, get the checklist, do all the things that you need to do. So on that level, you could say that computers didn't make things more efficient. But once they've done it once, they've done it for, that's it, throughout the hospital. So the savings might not be right at that one point of time. It might be just as a system, you now have the order in there, you have the patient details in there, it's accessible to everybody, people can see it. It's not like they have to run over to a cabinet or a drawer to pick up a piece of paper, bring it back and look at it. It's all done. So, we tended to look at it like it was a substitute for a previous way of doing things. IT should be seen more as an innovation. We have to change the way we plan and do things. And that sort of innovation, that sort of change is not very easy. If you don't have a good research background, if you don't have evidence about things, people can sort of turn off very quickly. So I think we've made improvements in that. There's more less resistance to IT. I think there's a greater there's more agreement about the potential that IT can have to change things. And I think that the other thing is that IT is no longer just a new thing. I mean, it's part of our world. It's hard to imagine existing without information technology. So that's what's when in a hospital, a new IT system doesn't come in like the first time anyone's seen a computer. It's now a new system that replaces an old system.
Yes.
So it's part of our environment now, and I think there's a greater acceptance of that. So therefore, the challenge is to provide the evidence and to evaluate and to improve things as part of just the part of the plan to implement.
And Andrew, do you have a sense that evidence is emerging that health informatics improves patient outcomes and quality and safety?
So there is evidence about it, and it's it's in some cases it's very dramatic. In some cases it's maybe not so dramatic. So in my area, when we introduced pathology ordering systems where doctors could make orders on a computer, we were able to show dramatic improvements in turnaround time. That is, the time it took an order to go in, or a pathology request to go into the lab, to the time a report was seen. So that's in some cases was up to 15 minutes. Now, on the ward, perhaps that doesn't make that much of a difference. I mean, a doctor might just do a round, and whether it comes in 15 minutes earlier or not probably doesn't make that much difference. However, in an ED, in an ICU, in a critical care setting, time does matter. So that's important. So there was a lot of evidence about that. But then there's other things. One of the big issues that's being debated around at the time is unnecessary ordering or major variations in ordering of tests and medications and medical images. Now, our study showed, and one that we've done actually quite recently, is that we looked at the difference between paper ordering and pathology electronic ordering, and we found that the electronic ordering changed things dramatically. There was less ordering done. Why? Well, one of the reasons that there's over-ordering is that sometimes a doctor doesn't know that a patient's had this test an hour ago, or another doctor's put in a request,
yes.
So there's a duplication, and sometimes they get picked up, but oftentimes they don't. So that when you can go to a computer and say, okay, well look, that patient has had that test 2 hours ago, there's no need to do it again. So that even that basic thing, basic piece of information can help improve the quality or the appropriateness of ordering. So yeah, there is evidence like that. In other things, it gets a bit more complex. So there's a lot of interest in things like patient portals. Patient portals which gives patients the information, the test results, and they can actually access it through a hospital information system where they get a login and they can go in and see their own record and maybe even get their results. Now, that's a very exciting concept. It's sort of a lot of people are very much for it because it encourages patient participation. It makes the patient management more a collaboration. But the evidence about how much good it's doing, it's a little bit more difficult because, it's a patient having access to information is a right, you'd say. It's valuable, but the evidence about where it's actually shown to be of value to everybody, it's a bit harder to judge that. So, there's many issues like that we confront and we need to deal with.
And Andrew, it's been fascinating talking to you this morning. I'm conscious of the time, but we haven't even touched on personally controlled electronic health records and the national scheme, or data security, and a whole raft of other things that I'd be fascinated to talk to you about and hear your views.
Yeah.
We'll leave that for another day, perhaps.
Okay, fine.
Today I've been talking with Professor Andrew Georgiou about medical informatics. If you've missed our interview and you've just tuned in, we have a transcript of it on our website at www.hpr.fm. We also have a SoundCloud archive, and you can find this interview on YouTube as well. Andrew, thank you for your time this morning. It's been a pleasure talking to you, and I'm fascinated to discuss things further with you on another occasion.
Thanks very much.
My pleasure. This has been the Health Academy with Health Professional Radio. My name is Wayne Buckler.